Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
This program is presented by Medscape Education Global.
Hello, I'm Mallory Zayatri. I'm a content neurologist and a specialist based in Arizona, and I want to welcome you to this expert roundtable on the use of anti-amyloid therapies for the treatment of Alzheimer's disease. I'm delighted to be joined today by great faculty and friends, Dr. Sharon Shaw, and also Dr. David Wiseman. So as an introduction, I think everyone knows that this is a very exciting time in our field in Alzheimer's disease. After 120 years, we've finally come to a point where we have biomarkers of the condition. We have definitions, understanding that the disease starts many years before clinical symptoms, and we can measure it during life. And finally, we have therapies that are considered disease modifying. And this is really, really important because so far we've had symptomatic medications that are very important. They are useful. However, they do not affect the underlying biology of the disease. And so what we'll see today is we'll look at converging evidence for the two amyloid plaque-lowering drugs that are FDA approved. They can slow down clinical progression by about 20 to 40%, at least in the clinical trials, and that this can translate to meaningful differences over time. But also with the caveat that these are not cures, and they come with burdens, costs, and potential side effects. And we need to be able to implement and translate these things from clinical trials into clinical care. And this is really the aim of the program today, so that we have a discussion, we review the evidence, what we know, what we don't know, what are the recommendations about these therapies, and what are the best ways to try to implement them and think about them. So first, I'm going to do a quick review of the clinical trial data. So these are the drugs that we have, lecanemab and donanemab, that are both now fully FDA approved. They both target amyloid plaques. They're not the same drugs. They affect different types of amyloid in the pathway, but ultimately they're given to the same types of patients, individuals who are confirmed to be amyloid plaque positive, and they're also in the right clinical stage. So they have to be the MCI or the mild dementia stages of Alzheimer's disease. The drugs are both infusions. They come with different frequencies, and they both have what we call, class side effects, which is amyloid-related imaging abnormalities. The efficacy data for both of these drugs from clinical trials, phase 3 trials, are definitive. In that, in the group of patients that are, met the inclusion-exclusion criteria, what you can see is that over about an 18-month period, there's amyloid plaque removal to the point of being considered amyloid negative by certain criteria after 18 months. That doesn't happen to everybody, but about 70 to 80% of the individuals in those trials were amyloid negative by the end of the trial. But the important part is that as it's affecting an underlying biological process, what you can see for the differences in groups is that there are reducing objective measures of cognition and function in a very consistent way. So no matter what is the primary outcome in these trials, whether it's the CDR sum of boxes or the iDRS, which is a combination of a combination functional scales that's a composite, or actually looking at just cognitive or functional endpoints or other composites, the data from these trials are very, very consistent. And consistently what they show is that if you give it to the right people in sufficient doses, to the right durations, you can not only remove plaques, which could impact slowing of the trajectory by about 20 to 40%. This can translate to an average over 18 months of equivalent of 5 to 7 months of relative saving of decline in time compared to a placebo. But what's also important is that this can translate into meaningful delays in milestones. For example, both clinical trials for lecanemab and donanemab show that you can decrease the likelihood of accumulating disability and going and progressing to the next stage of severity in Alzheimer's disease by about 35 to 40%. What do I mean by that? If you go, for example, from the MCI stage to the mild dementia stage, you've now gone from being independent to being dependent, and or going from the mild dementia stages to moderate dementia stages, really being dependent for many activities of daily living. And again, even during these 18 months trials, the risk of going from a full stage from MCI to mild dementia to moderate dementia was mitigated by about 35 to 40%. And these clinical trials went for 18 months. So we don't have randomized, double-blinded, placebo-controlled data beyond that, but we also have data from open label and extension parts of these trials that suggest that the benefits continue over time. And with disease-modifying drugs, the proposition is that at least over a certain period of time, while that disease process is still quite active or impactful, by mitigating it, you could actually increase the expected benefit over time. And that still has to be shown. But again, these are not cures, and there's no expectation that we give to patients that they're going to get better. So along with that, as I mentioned, there are limitations in the burden and safety considerations. Currently, both of the lecanemab and donanemab are infusions. And as I mentioned, it's not a good fit or option for every person in AD. They really have to qualify to be in the right stage, have amyloid confirmation, have MRIs at baseline and for monitoring purposes to mitigate the risk of ARIA. And ultimately with ARIA, even though during clinical trials, they were detected usually under monitoring MRIs where about 2/3 to 3/4 were really not symptomatic. And usually with a management and a mitigation plan, including sometimes pauses in the infusions, ARIA went away. Uncommonly, ARIA can result in serious symptoms, including hospitalization and rarely in disability or death. So this is really something that is important for us to consider. So that's a very, very quick review. There are, again, very key differences between these. Again, frequency of administration is going to be different between lecanemab and donanemab. One's every 2 weeks infusions, the other one's every 4. Donanemab had a different paradigm in the sense that it also not only looked for amyloid confirmation, but tau. And in the trials, only included individuals who had that had at least moderate or higher amounts of tangles in their brain. All right, so I'm going to pass it on to Sharon, who's going to talk about a very, very important part of this process, which is selection of the appropriate patients and how we discuss this with patients and families.
Thanks for that great summary. Yeah, when we think about who's right for these drugs, we really want to have the candidates, patients who were mimicking what we enrolled in the clinical trial, because people outside of those qualifications, we don't know if the efficacy is the same and the safety is the same. So in general, the FDA approved lecanemab and donanemab for patients who have mild cognitive impairment or mild dementia due to underlying Alzheimer's disease. There needs to be evidence of amyloid in the brain, and the ways that we can do that now are confirming it by CSF or amyloid PET. Because of the ARIA risk, and ARIA is amyloid-related imaging abnormality, we can have 2 versions of this, edema or hemorrhage. And because of that risk, which is different for each drug, the best way to detect for ARIA, because majority of it is asymptomatic, is with MRI. So patients need to be able to tolerate not only one MRI, but multiple MRIs. So patients need to be counseled about being able to tolerate the MRI and making sure that they're able to get it, that they don't have a pacemaker or some other exclusionary reason for getting an MRI. Patients and families need to also know that APOE4 genotyping is important because that can help stratify risk for them for ARIA as well. So consenting for that and having a discussion about the individual risk for that patient. Also, patients need to have a screening test with a mini mental status examination or Montreal Cognitive Assessment. In the clinical trials, there were different requirements. For lecanemab, the MMSE was 22 to 30, and for donanemab, it was 20 to 28. And insurance, depending on the insurance, may allow or cover based on MMSE score or MoCA score. So making sure that you have the right candidate for treatment and making sure that we have appropriate counseling with patients and family. Other considerations would also include BMI at the extremes of the body mass index, whether it's too low or too high, and also thinking about whether patients have family members who can walk them through this journey. As you might expect, it's frequent visits to the clinic, infusion center, imaging, and counseling. So making sure that there are an appropriate support structure for those patients. And so if we go on to think about who's not right for treatment, patients who are high risk for ARIA. So patients who already have evidence of greater than 4 microhemorrhages, macrohemorrhages, severe vascular cognitive impairment, or people who have bleeding disorders or other clotting disorders that might make them at a greater risk for bleeding is important to suss out and exclude and have that discussion that this is not the right treatment for you. Patients who have more advanced dementia or do not have Alzheimer's disease are not appropriate for this treatment. We also want to make sure that patients who have other comorbidities, such as a history of stroke, TIA, transient ischemic attack, or seizures within the past 12 months are really counseled about how this may not be a safe treatment for them, and other severities such as medical illnesses or psychiatric conditions that would limit their ability to participate in these frequent visits to the clinic, other immune disorders, and as I said earlier, contraindications to having an MRI. Now, one thing to note is the package inserts for both of these drugs say to use caution when patients are taking anticoagulants. However, the appropriate use recommendations, and one of the authors is Ollie, one of our colleagues here today, suggests that we should not be prescribing these drugs when patients are on anticoagulation until we have more data about the safety of this. And this is something that I follow in my practice also, is that patients who are on anticoagulation, we would not think that they are appropriate for these treatments. Other individual considerations, so depending on the APOE4 genotype, whether someone's a heterozygote or homozygote, there are increased risk for ARIA. So making sure that patients and families are counseled appropriately about their individual risk as it would go higher. The ARIA risk would be higher for those patients who are both heterozygote and even more for homozygotes. Really thinking about the individual comorbidities and whether they're appropriate for the treatment in that personalized discussion. Also thinking about with patients whether they live far from an infusion center or from your practice. Lecanemab is given every 2 weeks currently as an infusion. Donanemab is given every 4 weeks as an infusion. So really thinking about the access for patients and families. Is this feasible for them? Is it feasible for them to obtain frequent MRIs? And how close are they to you and an emergency care or imaging in case there were changes or sudden evaluation that was required? I mentioned earlier that having a care partner or support structure is really key to making sure that patients can continue with these treatments, and having an appropriate discussion with financial counselors from your institution about what their individual burden would be on cost and copay. Finally, making sure that patients understand this is not a cure, as Ali had said. This is really disease modifying. It's really decreasing the risk of progression of the disease over time. And we don't know whether patients who have other comorbidities, because they tended to be excluded from the trials, whether they'd have the same benefit, whether they'd have more safety concerns, and whether patients who have atypical forms of Alzheimer's disease, do they benefit the same way? We don't have a lot of data as of now about different patients who have different race and ethnicities, really understanding age and whether they're more likely or less likely to benefit, and sex as well. So really thinking with the patient and family about their individual risk, their cost, risk of ARIA, infusion reactions, and the burdens of visits. Anything else that you, Dave or Ali, would make sure you counsel your patients about, or how do you have that discussions with them?
I think there's a lot of like nonverbal communication that happens in the room between these people who are really mild and they have preferences. Some of the most risk tolerant people I think I've ever met have been faced with this disease, and they're just like, I don't care. I will take any risk rather than being like my brother, my uncle. And they tend to be APOE4 carriers, so they're at higher risk. And then, sometimes there's discord between the patient and their caregiver. And that's always like a troublesome area to broach. But usually at the end of the conversation, we can all kind of be on one page and make a decision moving forward. Unfortunately, the decision itself is binary, either treat or not. There are no half measures here.
It's such an important point. I think I do see that discord in my patients and families. And sometimes it's just as you said, and sometimes it's the opposite, that the spouse is really pushing and the patient is a little more complacent about it. So coming to that same page. The only thing, like you said, that I would say differently is sometimes it is binary. You treat or you don't treat, but sometimes you can stop. You say, if there's a problem, we'll stop. Don't, it isn't the same sort of risk though, as a lot of the symptomatic therapies that we have. Ali, any other comments?
Yeah, no, I agree. I think you covered it really well. And I think one of the issues is it's this patient-centered, informed, shared decision-making process about the totality of options, including the monoclonals, the risks, benefits, the knowns, the unknowns, right? The things that are still to be worked out really requires a process. And it's not one conversation. I find that it's multiple conversations and a process over time. And like you said, Sharon, it doesn't stop with even starting treatment. It has to continue throughout the process, because then we have to decide when to stop, how, and things like that. One thing that we do is we actually do an informed consent at documents, right? And including all the partnership that's required, sort of the shared responsibility, so that we can manage the risk together. And that's really, really important. But focusing on the fact that people, they should have this as an option, and there should be the justice for people to be able to choose this, not just people who are wealthy and can pay for it. I think those are important things.
That's a wonderful point. Thank you. We also have an informed consent and wallet cards and things like that. It's really important.
Exactly. All right. So this brings us a very good point to throw it over to Dave about risk and monitoring and how to manage it.
Yeah, thank you. So the risk is all this thing called ARIA. It's been mentioned before, and it's a class effect. It's really important. This amyloid-related imaging abnormality, and you really want to keep this as an imaging-only abnormality and not create a serious adverse event or hospitalization. So, and the way to do it was with monitoring. But before we even get into it, what is it? So what happens in this disease is that the amyloid is sticking to their brain cells, and that's creating their memory and thinking problems. But the amyloid is very sticky, and it also gets into these tiny little capillaries. And when we get rid of the amyloid, the capillaries, by some mechanism, it's not really fully worked out, they become leaky. Pores form in the capillaries, and they leak out, and small holes will leak out fluid, plasma, and bigger holes will leak out blood. And so plasma, edema, ARIA-E, blood, ARIA-H. And they're representative slides here. You can see the flare, these diffuse, fluffy periventricular and subcortical white matter changes. That's ARIA. That's just diffuse ARIA in one of my patients. And it's usually co-localized with the ARIA-H. And of course, that would be the case, right? Because the pore has just gotten bigger and it allowed some red blood cells to get in and stain the brain and kind of think about like a tattoo on the brain, because they're probably not going to go anywhere after they get into the brain parenchyma. And so that's what we're seeing on the right, ARIA-H, okay? And so ARIA-H is part of the natural phenomena of this disease. It happens about 5% per year in all the trials people getting placebo. And the way it presents, these little tiny microhemorrhages, which you can see on the left, little tiny microhemorrhage right on the left hemisphere there, and superficial siderosis, where one of the microhemorrhages was just on the cortex, and it kind of eroded into the subarachnoid space. And so the hemosiderin is in the subarachnoid, and it kind of looks like a gyrus. Now, the therapies permit up to 4 microhemorrhages. And there's a little bit of a difference with the superficial siderosis. Donanemab permits 1 area, and lecanemab cannot allow any. But you have to be careful here, because any microhemorrhage implies that these people have enough cerebral amyloid to leak spontaneously. And so by messing with it, you can produce more leaks and you can produce more ARIA. And so that is an additional risk factor for this ARIA. So be careful. And the other big risk factor is a gene called APOE. And so we all have different variants of APOE, and people who have APOE4, and especially homozygous APOE44, are really at increased risk of the disease, and they're really at increased risk of the side effect ARIA. And it's stratified here, as you can see, from lecanemab and donanemab. And you're never going to remember these numbers, but it increases with the dose of APOE4. If you have 1 copy of APOE4, it increases the risk. And you can see from 5 to 10%, almost doubles for lecanemab, 15 to 22 for donanemab. And then if you have 2 copies, APOE4/4, it really increases the risk. But one interesting thing that kind of hits me about this is it's part of the disease. ARIA is part of the disease, and you can really see the placebo people evenly matched, and also increases with APOE4. And so the inclusions are, as listed here: get a recent MRI. For lecanemab, 0 superficial siderosis. Donanemab permits 1, 4 or less microhemorrhages, and no macrohemorrhages or other significant lesions. And here's what happens when you mess up. Here's a case of ARIA that was missed. It was missed on a local read and missed on a central read in a clinical trial. And you can just see this little sort of wispy ARIA that really you can only see it in retrospect, but you do see this asymmetry. And they were dosed again, and you see this exploding ARIA. Now, thankfully, the patient was asymptomatic, but this ARIA lasted for about 5 or 6 months. But again, just kind of keep it mild. And the way to do that is with MRI monitoring and really, really vigilant about the ARIA. Okay, so it's been covered about how to prevent ARIA, and that's right patients and right discussions. And one thing I've really adopted, you cannot be nihilistic with a disease-modifying therapy that's becoming standard of care. So no nihilism with diagnosis, disclose. It should be a crisp discussion, crisp disclosure, and a balanced discussion. This is not a cure. It has risks, but it's something. And getting the right patient means getting an MRI, getting APOE, and getting biomarkers, and looking for that reliable caregiver. Not reliable, not a good fit. And then the right monitoring and the right lesson. So you're going to the listener here is going to get experience with these drugs and listen to that experience. And there's a great quote from Tupac. I love it. Trust me, I never lose. I either win or I learn from it. You know, it's an iterative process. Lean into that. And hopefully you learn from other people's mistakes. Be comfortable with being wrong. I am wrong. I see somebody, I say you have early Alzheimer's disease. I believe that you have this thing called amyloid building up in your brain, and we're going to get a PET scan, and it is negative. And there's a negative PET scan right here. I was wrong. There's no target. We're not going to fire because there's no target. Obviously, no amyloid. There's no need to remove further amyloid. And be comfortable with risk tolerance. Oncology and stroke have extremely high risk tolerance from the doctor's perspective. And it's really time for neurologists to adopt that emotion and ethos. And with ARIA, keep it mild, keep it asymptomatic. There's a superficial siderosis at the top. You look at your images and really think worst case scenario. This is bilateral superficial siderosis. This is not bilateral head trauma. This patient never hit their head. This is all Alzheimer's, just part of the disease. And tracking. So know ARIA. Know when ARIA occurs. ARIA is a front-loaded event. So for lecanemab, and again, you can forget these numbers again, just keep them on track. They have different tracking. Lecanemab before 1, 5, 7, 14, and just every 6 months after that. And there's one added one for donanemab because maybe there's increased ARIA, and one other MRI, again, to monitor them and keep them safe. ARIA is typically early, and it is stratified by the APOE4. So the people who are 4-4, they're still at increased risk moving forward. But if you see APOE 3-3, they're really at minimal risk after the first 6 months or so. And here's our tracking system. Here are two representative, fake patients who got appropriate workup. We have all their information, and now they're ready to go. And you can see that the MRIs are different depending on what we choose to implement, either donanemab or lecanemab. Okay, and the way to do this, I would say that if you're part of a big healthcare system, don't create a new wheel. You have clinical acumen. Doctors have a great deal of ability. They're smart. You can figure it out. If I can figure it out, you can figure it out. And then you got to get the labs. You got to get APOE. You have to get MRIs. You either have to sharpen up your needle and get an LP if you're in a PET scan desert, or get PET scans, and then use your own infusion places that are already pre-existing. And the only people you really have to deal with are other stakeholders from insurance and maybe internal stakeholders who are like, no, we have to analyze it, and we don't know. But talk to them and say, look, we have to do what's right for the patient in front of me.
Sharon, is there anything you want to add to Dave's points here?
No, I love how he basically tells us we got to roll up our sleeves and do the work. Like, it's just one. Also, I've never had anyone else quote Tupac, but I love this sort of that it is iterative, and patients who are asymptomatic and feel like this is helping, they may want to move forward. But there may be people after getting ARIA, but there may be people who get scared after they have an ARIA event. So really having that discussion, and again, iterative as they move through treatment.
Yeah, and I like, Dave, that we have to be humble about the things we know and don't know, and very transparent about those things. But also rigorous and move forward and be able to give provide these options to people, whether they're monoclonal symptomatic drugs, lifestyle changes, behavioral modifications. They're not mutually exclusive, so they should all be presented. So. All right, so we're going to switch now. And Sharon, can you tell us a little bit about more longer-term management and what considerations are there?
Yeah, we sort of briefly touched upon this too. Sort of, again, as we say, this is sort of iterative, right? As patients move through that first ARIA risk 6-month time point, and maybe they're cruising a little bit, but there are continuing ongoing discussions about risk benefit, maybe tolerance for patients because they're getting sort of burdened of coming to the clinic or the infusion center, or they may have had ARIA and they are a little concerned about continuing with treatment. Potentially also thinking about patients who move out of that MCI and mild dementia stage, but to a moderate dementia stage. Do we continue to treat? is this still the same benefit to risk ratio at that point? We don't have a lot of long-term data at this point. So I think it's really having that discussion with you and the patient and family to say, okay, is it now continuing to be worth it for you and worth it, depending on what that means to the patient in terms of time, money, et cetera, and thinking about that. And then just some specific considerations with lecanemab and donanemab. So with lecanemab, we may have already said that this is prescribed every 2 weeks as an infusion. And because it's targeting both the plaques and the protofibrils, the thought is that we need to keep continuing to treat indefinitely. There isn't a stopping criteria as of right now or maintenance therapy as of right now. There may be changes that come forth in the future, but as of right now, it should be given every 2 weeks. And a presentation at a conference early this year by Chris Van Dyke and others had demonstrated that the patients who were getting treatment and compared to those who were on placebo and then got treatment in the open label extension portion of the trial continued to have benefit. There was no cohort that they compared to who continued to have a placebo in that open label extension. But in that presentation, Chris Van Dyke showed and compared it to an ADNI cohort. So patients who had continuous testing with no treatment. It's an observational cohort of research patients and how they would progress over time. And when compared to the treatment cohort of people who had a delayed start, who had treatment from the beginning, and the observational cohort, he demonstrated that there's a continued separation of benefit over time, meaning that there's less decline over time, potentially that this ongoing treatment with lecanemab will continue to benefit the patient. We compare that to donanemab, where there is stopping criteria. In the clinical trial, patients had a repeat amyloid PET scan at week 24. That's a 6-month time point. And if they had the centiloid scale less than 11, which is considered negative, they were switched over to placebo. Or if they had 2 consecutive PET scans that were in the centiloid scale from 11 to 25, again, considered sort of negative by visual read, they switched over to placebo. And so in the results of the JAMA paper, we see that about a third or 30% of patients were able to stop treatment by having an amyloid PET determined negative by 6 months. 66% of patients by week 52, or the 1-year mark, were able to stop treatment. And then by the end of the treatment period, about 18 months, 76% of patients were able to stop treatment. So it might make us think about, when do we repeat an amyloid PET to consider stopping treatment for donanemab? And there are no clear defined appropriate use recommendations as of right now. I'm sure Ollie's going to work on that vigilantly. But we might suspect that maybe at a year time point or 18-month time point, we may consider repeating an amyloid PET if we got one at baseline to determine whether we can stop treatment. And knowing that a majority of patients who are treated would probably be able to stop treatment. Or thinking about what the patient and family burden is, should we stop treatment? So other things to make sure is to keep that discussion open with the patient and family so that we can make sure that they're safe and that they understand the continued risk and continued benefit over time. Any other comments from you, Dave and Ollie?
Yeah, I agree. I think that we are a little bit ahead of where the clinical trials took us. And so we just need to be very thoughtful as data comes out from biomarkers, et cetera, about some potential maintenance dose in the future and what that may be, or how much of a grace period one will have when amyloid is removed. Well, I want to thank you both for really condensing a lot of information very quickly. To summarize, I would say that we're in a new era, which is a completely new paradigm that impacts all levels of care, including the first level, which is a timely and accurate diagnosis that really needs to be done if we want to catch people early enough where potentially actually these therapies may be even more effective. So it requires a shift in our perspective, as we've heard, knowledge, our appreciation, proficiency, even our language and our behavior. And we need to have our systems catch up to what we've learned in clinical trials. And we know that the risk of ARIA or class effect, the priori risk is not equal among everybody with AD and can depend on several patient-related factors. And so we need to have a well-informed and ongoing patient-centered kind of a shared decision-making process that gives people realistic expectations about these drug therapies. But, I think all of us share the excitement that the paradigm has shifted, that we need to really intervene early, and kind of going back to the paradigm to MS and other conditions. We shouldn't wait until there's widespread irreversible loss in brain cells until we intervene really, right to that point. So earlier diagnosis, accurate is better. We don't wait for in cancer for it to metastasize. We don't wait for heart failure to become end stage. We don't wait for osteoporosis for people to have fractures before we treat that. So I think we need to think of it that way in Alzheimer's too. And I think there's a rational basis for hope that not only this era of medicines is going to be important for the people now, but really hope for the future as we learn to do more precision medicine with people and really think about secondary prevention even earlier. And those trials are ongoing to see if we can prevent. And we know that amyloid is only a part driver. So we need to think about combination therapies. So with that, I just want to close and thank you again, Sharon and Dave, for a really interesting and informative discussion. And thanks for the audience for participating in your attention. And please continue to answer the questions that follow. And please complete the evaluation for this to give us feedback. Really appreciate it. Thank you, everyone.
This program was presented by Medscape Education Global.